So now we will discuss about the approach to the management of the asthma. There are the 5 steps for the management of the asthma. Number 1 is assessing the control and severity of the asthma. Number 2, distinguishing between the severe asthma and uncontrolled asthma. Number 3, personalized pharmacologic therapy for the asthma. Number 4, the treatment of the modifiable risk factors and the control of the environmental factors. And number 5, guided self-management, education and skills training. Now first of all, come to the first step, that is the assessment of the assessment of the severity and the control of the asthma. So the classification of the asthma severity is based on 5 components of the severity, and these are the symptoms and use of the beta agonist, nighttime awakenings and interference with the normal activity and the lung function tests. Asthma severity is broadly classified into the intermittent asthma and persistent asthma. Intermittent asthma is said to be when the symptoms are less than 2 days per week and the use of the beta 2 agonist are less than 2 days per week. Similarly, less than 2 times per month nighttime awakenings will be in the intermittent asthma, while the interference in the normal activity and the lung function test will not be affected. And in case of persistent asthma, which is further classified into the mild persistent asthma, moderate persistent asthma and severe persistent asthma. In case of mild persistent asthma, there will be more than 2 days per week symptoms, and the use of the beta 2 agonist will also be more than 2 days per week, while nighttime awakenings will be 3 to 4 days per month. While there will be minor limitation in the normal activity of the person, well, the lung function test will be normal in case of mild persistent asthma. In case of moderate persistent asthma, there will be daily symptoms and the use of the beta 2 agonist will also be daily, and the nighttime awakenings will be more than once per week, and there will be some limitation in the lung normal activity of the person, and also there will be FE1 will be reduced. It will be less than 80%, but will be more than 60%, and the ratio of the FE1 FEC will also be reduced, but will be less than 5% reduction. In case of severe persistent asthma, there will be throughout the day this person will be having the symptoms, and in a day person will be using several times of the beta 2 agonist per day. Several times person will be using beta 2 agonist, and also there will be often nighttime awakenings about 7 days per week, and interference in the normal activity will be extreme, and lung function test will be severely affected, like less than 80%, less than 60%. This is the difference between the moderate asthma and the severe asthma. In the moderate asthma, FE1 is less than 60%, less than 80%, while in case of severe asthma, FE1 is less than 60%. Now come to the control of the asthma. The components are the same, almost same. Daytime symptoms, limitation in the normal activities, nighttime symptoms are nocturnal awakening, use of the reliever or rescue treatment, and the lung function like PEF or forced expiratory volume or peak expiratory flow meter. So according to on the basis of control, we will have the 3. It will be whether it will be controlled, whether it will be partly controlled, or whether it will be uncontrolled. When daytime symptoms about twice or less than twice per week and are either none. When need of the reliever or rescue treatment is also either none or twice or less than twice per week, while there will be no limitation in the activities, no nocturnal symptoms, and lung function test will also be normal, then we will classify it as a controlled. Then we will call it as a controlled, while the partly controlled is called when there are more than twice per week daytime symptoms, and the use of the reliever medications is also twice per week, and there may be the limitation in the activities or nocturnal symptoms, and the FE1 is less than 80% of the predicted in case of partly controlled asthma. While uncontrolled asthma, there will be 3 or more features of the partly controlled asthma. So we will differentiate between this, whether it is a severe asthma or whether it is the uncontrolled asthma. We must assess the inhaler technique, medication adherence, comorbidities such as obstructive sleep apnea or GERD or ongoing exposure to the allergens as causes of poor asthma control, that is uncontrolled asthma. If the patient is still requires the step 4 or 5 therapy after these issues have been addressed, then the patient has severe asthma and should be referred to a pulmonologist or asthma specialist. Third step in the management of the asthma is personalized pharmacotherapy of the asthma management. Personalized asthma management is a continuous cycle that involves the assessment and treatment and review with the goals of symptom control and minimizing the future risk. Management should include stepping up therapy if the asthma remains uncontrolled despite adherence at good inhaler technique, and stepping down to find minimum effective therapeutic dose. In case of mild persistent asthma, the step 1 or 2 will be the treatment of the choice, while in case of moderate asthma, step 3 will be the treatment, while in case of severe asthma, 4 or 5 step is required for the treating the patient with asthma. Pharmacologic agents for the management of the asthma are the long-term controller medications and reliever medications. This is the personalized asthma treatment, and in this there are the two tracks for the management of the asthma. Track 1, in which the reliever is low dose inhaled corticosteroid along with the formoterol, and it is the preferred approach recommended by the GINA when the patient at any step has asthma symptoms. They use low dose inhaled corticosteroid along with formoterol as needed for symptom relief. In step 3 to 5, they also take the inhaled corticosteroid and formoterol as regular daily treatment. This approach is preferred because it reduces the risk of severe exacerbations compared with using a SABA reliever with similar symptom control. In track 2, SABA is used as the reliever. It is an alternative if the track 1 is not possible or if the patient is stable with good adherence and no exacerbations in the past year on their current therapy. And in step 1, patient takes SABA and low dose inhaled corticosteroid together for symptom relief in combination or with ICS taken right after the SABA. In step 2 to 5, the reliever is a SABA. Before considering the SABA reliever, consider whether the patient is likely to be adherent with their ICS containing controller therapy, as otherwise they would be at high risk of severe exacerbations. Patient is having the symptoms but less than 4 to 5 days per week. This is like in the mild persistent asthma. We will give the treatment as low dose inhaled corticosteroid and formoterol. In step 3, low dose inhaled corticosteroid and formoterol will be given, and the symptoms most days are waking with asthma once a week or more. In step 4, if the patient is having step 4 is like patient is having the moderate persistent asthma, having the daily symptoms of asthma, and the waking of the asthma is once a week or more with low lung function. So in step 1 to 3 is given in case of step 1 to 3 include the low dose maintenance inhaled corticosteroid along with formoterol, and it include the it is in step 1 it is like more mild persistent asthma, while step 4 is given in case of moderate persistent asthma. While in case of severe asthma, short course of oral corticosteroids may also be needed for patients presenting with severely uncontrolled asthma. In step 5, we will add LAMA along with LABA and ICS, and we will also refer patient for assessment of the phenotype, and we will consider anti-IgE and anti-interleukin 5, interleukin 4. Track 2 includes when the patient is having symptoms less than twice per month, we will consider it as a step. We will prefer as a step 1 treatment, and the step 1 treatment include the ICS whenever SABA taken. And when the patient is having the symptoms twice a month or more but less than 4 to 5 days a week, then we will consider step 2, and in the step 2 include the low dose maintenance ICS. And when the patient is having symptoms most days or waking with asthma once a week or more, then we will consider step 3. Step 3 include the low dose ICS and low dose maintenance ICS and LABA. When the patient is having the daily symptoms or waking with the asthma once a week or more and low lung function, then step 4 will be considered, and it includes the medium or high dose inhaled corticosteroid along with the LABA. And the severe asthma, also severe uncontrolled asthma, requires the short courses of oral corticosteroids as well. And similarly, now we'll discuss the drugs used in the management of the asthma. The drugs which are used in the management of the asthma are basically major two types, with either they are bronchodilators on the basis of function. On the basis of action, they are broadly classified into two types: either they are bronchodilator or either they are anti-inflammatory agents. The drugs which act as bronchodilator are the beta 2 agonist, muscarinic antagonist, either muscarinic antagonist or methyl xanthines. And another way of action of the drugs of the asthma are the anti-inflammatory drugs. These anti-inflammatory agents include either they are degranulation inhibitors, either they are antibodies, either they are corticosteroid therapy, or either they are leukotriene modifiers. Corticosteroids are further classified as the inhaled corticosteroid and oral corticosteroid, while the leukotriene modifiers are of two types: either lipo-oxygenase inhibitor or receptor blocker. Lipo-oxygenase inhibitor include the xylutine, while the leukotriene receptor antagonist include the zafirlukast and montelukast. And the degranulation inhibitors are basically the mast cell stabilizer, and they are include the nidochrominil and chromonil sodium, either by the antibodies which are used in the asthma. They are divided into three categories: long-term controller medications, reliever medications, and add-on therapies. Long-term controller medications are used to reduce the airway inflammation symptoms and risk of future exacerbations, while the reliever medications are used as an need-on basis to relieve the breakthrough symptoms, while the add-on therapies are used for severe asthma. Revising will be absent. In the pulse, if we'll see the pulse, in mild cases pulse will be less than 100, while in the moderate pulse will be 100 to 120. In severe pulse will be more than 120, while in the respiratory arrest imminent, there will be a patient will be having bradycardia. In the pulsus paradoxus, in the sixth component is the pulsus paradoxus. In pulsus paradoxus, in mild case there will be no pulsus paradoxus, while in moderate case there may be pulsus paradoxus and it will be about 10 to 25 millimeter Hg, while in case of severe asthma exacerbation there will be more than 25 millimeter Hg pulsus paradoxus. While in case of respiratory arrest imminent, there will be absence of the respiratory, there will be no pulsus paradoxus, and the respiratory muscle will be having fatigue. And in case of functional assessment, PEA for FE1 predicted or personal based. In mild cases it will be more than 70%, while in case of moderate 40 to 69%, while in case of severe it will be less than 40%. In case of respiratory arrest imminent it will be less than 25%. PaO2, partial pressure of oxygen, in case of mild it will be normal, in case of moderate it will be more than 60 millimeter Hg, while in case of severe it will be less than 60, and there may be the cyanosis. In case of respiratory arrest imminent, there will PaO2 will be less than 60%, and there will also be cyanosis. PCO2 in case of mild it will be less than 42, and moderate it will be less than 42 as well, while in case of severe it will be more than 42 millimeter Hg. while the saturation, oxygen saturation in case of mild it will be greater than 95%, in case of moderate it will be 90 to 95%, while in case of severe it will be less than 90%. Respiratory arrest imminent, it will also again will be less than 90%. Treatment of acute exacerbation include the initial assessment, airway, breathing, circulation, and we will check whether the patient is having the drowsiness, confusion or silent chest. If these things are present, then we will consult ICU, start SAVA, and if patient is having these symptoms, we will consult ICU and start SAVA and oxygen and prepare patient for intubation. If patient is not having these symptoms, then we will do further triage by clinical status and according to the worst features. If the patient is talking into phrases and prefers sitting than to lying and is not agitated and respiratory rate is increased, the accessory muscles are not used and the pulse is about 100 to 120 and oxygen saturation is 90 to 95% and if PEF is greater than 50% predicted of the best, then we'll consider it as a mild or moderate. If the patient is talking in words and sits in hunched forward, agitated, and the respiratory rate is greater than 30 per minute, accessory muscles are used and the pulse rate is greater than 120, oxygen saturation is less than 90% and the PEF is less than 50%, then we'll consider it as a severe. In case of mild to moderate, we will start the short-acting beta-2 agonist, consider ipratropium bromide and also controlled oxygen to maintain the saturation 93 to 95%. And oral corticosteroids, while in case of severe, along with all these short-acting beta-2 agonist, ipratropium bromide, controlled oxygen to maintain the saturation 93 to 94%, oral or IV steroids, will consider IV magnesium sulfate and consider high-dose inhaled corticosteroids. If continuing deterioration, treat severe and reassess for ICU. Assess clinical progress frequently, measure the lung function in all patients 1 hour after initial treatment. If the FE1 or PEF is 60 to 80% of the predicted or personal-based symptoms improved, consider discharge or planning. If the FE1 is less than 60% of the predicted or personal-based or lack of clinical response, severe, will continue same treatment as above and reassess frequently. In mild cases, inhaled short-acting beta-2 agonists are needed at increased doses every 3 to 4 hourly for 24 to 48 hours. If patient is not improving after 48 hours, then 5 to 7 day course of oral steroids is given. Goals of treating the moderate exacerbation are correcting the hypoxemia, reversing the airflow obstruction, and reducing the likelihood of obstruction recurrence. Instructions in the self-assessment and follow-up appointment and action plan for managing the recurrence. And in case of severe patients, all patients with severe exacerbation should immediately receive oxygen, high-dose inhaled short-acting beta-2 agonist, and systemic corticosteroids. Supplemental oxygen should be given to maintain the saturation greater than 90% and partial pressure of oxygen greater than 60 mm, and oxygen-induced hypoventilation is extremely rare in asthmatic patient, and concern for hypercapnia should never delay the correction of the hypoxemia. And frequent high-dose delivery of the short-acting beta-2 agonist is indicated and well tolerated in severe airway obstruction. At least 3-meter dose inhaler nebulizer treatment should be given in the first hour of the treatment. Some studies suggest that continuous therapy is more effective than intermittent administration of these agents, but there is no clear consensus as similar doses are administered. Ipratropium bromide reduces the rate of hospital admission when added to inhaled SABA in patients with moderate to severe exacerbations. Systemic corticosteroids are added, and IV magnesium sulfate 2 gram over 20 minutes is not recommended for routine use in asthma exacerbation. However, 2 gram infusion over 20 minutes may reduce the hospitalization rate in acute severe asthma when the FE1 is less than 25% of the predicted on presentation. Multiple studies suggest that infection with viruses, rhinovirus and bacteria, mycoplasma pneumonia, chlamydia pneumonia predisposed to acute exacerbation of asthma and may underlie chronic severe asthma. The use of empiric antibiotic, however, is not recommended in routine asthma exacerbation, so there is no consistent evidence to show improved clinical outcomes. Antibiotics should be considered when there is high likelihood of acute bacterial respiratory infection, such as when the patient has fever or purulent sputum and evidence of pneumonia or bacterial sinusitis. In emergency department settings, repeated assessment of the patient with severe exacerbation should be done after initial dose of inhaled SABA and again after 3 doses of SABA 60 to 30 minutes after initial treatment. Response to initial treatment is the better predictor for the need of hospitalization than is the severity of the exacerbation or the presentation. And discharge to the home is appropriate if the PEF or FE1 has returned to 60% or more of the predicted or personal based, and if the symptoms are minimal or absent. In intensive care setting, a small subset of the patients will not respond to treatment and will progress to impending respiratory failure due to combination of worsening airflow obstruction and respiratory muscle fatigue. In such case, patient can deteriorate. They must be monitored in critical care setting. Intubation of an acutely hypertension commonly follows administration of the sedative medications, initial positive pressure ventilation. Controlled hyperventilation with permissive hypercapnia is of not meeting the asthma therapy after 3 to 6 months of therapy, uncontrolled symptoms despite moderate dose inhaled corticosteroids, occupational asthma in case of complicated comorbid problems like rhinosinusitis, tobacco use. Atypical presentation or uncertain diagnosis of asthma, particularly if